Hello, welcome to The Long Road. I'm your host, Chris Roberts. I'm here with my guest,
Dale Pollock.
Marnie Silverstein.
And today's show is going to be a little bit different. We're going to talk about pink eye, that old curse that we all knew when we were much younger. And so, could you tell me a little bit about your background?
Well, I'm one of the ophthalmologists at the Cheshire Medical Center, Dartmouth Hitchcock Keene. And ophthalmologist is somebody who's been trained medically, just like any other medical doctor. We've been through medical school and at some point along the way decided that we wanted to specialize in eye diseases and treating eye diseases. So unlike the optometrists who are not so medically trained, we're trained just like the pediatricians, radiologists, orthopedic surgeons, and then after medical school, we do specialty training just in ophthalmology.
So you would do surgery like for cataracts and other problems?
Correct.
And you?
And I'm one of the general pediatricians at the Dartmouth Hitchcock Keene Clinic, Cheshire Medical Center. Unlike Dale, Dr. Pollock specializing in eyes, I, as a general pediatrician, kind of take care of everything for kids, but obviously don't have the specialty training, and so I send kids on to other people for more detailed care. So so we get trained, go through medical school and then residency and training in, sort of normal growth and development of children, and then all of the problems that can come up, all of the different diseases and illnesses, and how to treat them, and at what point to refer to a specialist and get some, some additional help and expertise in taking care of a specific problem.
So if you, for example, if a child may be dyslexic, you may pick that up and then send it to Dr. Pollock? Or the other way around?
For dyslexia, I think we would send them to Dr. Pollock or one of her colleagues in terms of ruling out a vision problem, and then likely involve the school and the developmental pediatricians and the folks there for further evaluation.
When I was growing up, pink eye was like having the measles or the chicken pox. You got pink eye, no one wanted to see you for maybe a week to 10 days. And it was like a big fear that you don't want anybody around pink eye because you're so contagious. Is that still the same today, or is there a lot of myths?
Well, unfortunately, a lot of the way people react to it is the same. But the reality and the studies show that, for the most part, pink eye is really just the common cold. Probably, looking at the studies, anywhere from up to 75% of cases of pink eye is the exact same virus that causes the common cold, except it's in the eye. So, a lot of the mythology still exists, and one of the reasons we're here is to try to change some of that and talk about, what is the disease and should people really be that frightened of it. And mainly it happens in the daycares and the schools where kids who have a little bit of pinkness of the eye get sent home and can't come back for a week or 10 days unless they're being treated with antibiotics. And the whole point of what we're trying to do is educate the community that antibiotics are not appropriate for a viral illness. And even exclusion criteria don't pertain anymore because we don't keep kids home from school who have a cold. This is the same thing.
When you're talking about the antibiotics, it's like you have a sore throat and they just used to give you antibiotics and you found out you didn't have strep throat, and that causes people develop resistance?
Correct. I think one of the biggest problems worldwide is antibiotic resistance as a result of overuse and inappropriate use of antibiotics. So one thing we would like to do is cut back on the demand, because the studies have shown that for most physicians, they will prescribe antibiotic if the patient demands it.
One of the things I used to hear from my mother and my grandmother, when someone had pink eye and they had the pus and everything, and they would say, well, we got to fix it, or you use that warm cloth, wipe the eye out, we got to do it, else you're going to go blind.
For the most part, that is just not true. The bacterial type, which does have more of the pussy, mucus, and discharge, is actually a benign a benign disease, and it will get better with no treatment probably in 7 to 10 days. In the bacterial type, treating with an antibiotic drop does shorten the course by 1.6 days. So, but it's really a benign self-limited disease. And even the viral types, same, benign self-limited disease. Very few viral ones will go on to create a chronic, long-term condition, which does require treatment with steroid eye drops, but that's something that really an ophthalmologist needs to diagnose and treat. So those are only for the people who, very small percentage of people who don't get better on their own in usually 7 to 10 days.
I was reading, it's easy to tell the difference between a bacteria and a virus. Do antibiotics work on viruses?
No, they don't. And I think it's been confusing because a lot of the symptoms do overlap. Basically, pink eyes, some discharge, lashes crusty. Probably the big difference is in the nature of the discharge. So the viral ones are really more watery, and the bacterial ones have the thick, mucousy discharge streaming out of the eye all day long. They also tend to be a little bit more common in the younger children, under age 5. You see more of the bacterial type. So the diagnosis may not be exact, but I think we can do a better job of differentiating and not treating every single one with antibiotic.
Before we go to the child care portion, well, there's a lot of chemicals in the house. And even some, for example, my daughter's toilet was clogged up. So I went there and put Mr. Plumber in, and all of a sudden my eyes are irritating, and this morning I got up, they were a little pink. How do a lot of parents confuse pink eye and eye irritation because there are so many chemicals around the house?
I think that's very common, and other things too can cause pink eyes, irritated eyes. Allergies is probably the other one that can look like an infectious condition, but it's not. Some things that can differentiate, of course, if you were exposed. Your situation is very classic. You were exposed to something and now your eyes red and pink and irritated. Or if it's that time of the year and
hay fever.
Exactly. And itching. Itching is more related to allergy type than the infectious type.
We were talking earlier that one of the most common places for pink eye is daycare. And again, a lot of daycares don't want their kids with pink eye because it's like, oh, it's a unhealthy atmosphere, or we're not doing the proper stuff. So again, that's kind of a myth. It's not a dirty place. It's not an unsanitary place. Sometimes it just happens.
I think it's very common. I think 1 in 8 children will have an episode of pink eye in any given year. So it's not a reflection on the daycare's cleanliness, but kids are susceptible. Marnie sees these or hears about them much more frequently than I do because, in fact, the parents call pediatrician first before we get involved.
And how would you tell some of the difference right off the bat that you can help or send to the ophthalmologist?
So I think with pink eye, we actually get a lot of phone calls about pink eye. We've been trying to do some triage over the phone and figuring out who do we actually need to see, who probably has viral and will get better on their own, who has bacterial and may or may not need treatment. So I think for pink eye itself, we generally won't refer unless it doesn't go away in that 7 to 10 days. If their vision seems very affected. So one of the things, if I do see somebody for pink eye, I'll test their vision and make sure that they're not way off on their, and I think you have to wipe the discharge away. If you're asking a kid to look through discharge, then, but am I correct that if if the discharge is gone, then there's not a physical barrier, their vision should be normal.
Definitely.
And so if I have a child coming in with red eyes and it's not it doesn't quite look like pink eye to me, and I'm not sure what's going on, and their vision is off, certainly I would send them to the ophthalmologist for that pink eye that is lasting more than the 10 days, whether treated or not, and whether I think it's bacterial or viral or not. There are, as Dale mentioned, some very specific infections that can cause more serious problems. So herpes infection, which is the same, it's a very common virus. I think similar to pink eye, people hear herpes and they get very upset, but it causes cold sores. Lots of people have it, and if kids get that, kind of around their eye, we can treat that. But if it seems to be actually in their eye, we certainly refer them. So, but I think for the kids coming in with, red eyes that are watering and they're not otherwise, they maybe have some cold symptoms, but they're not, extremely ill, or that classic matted shut and pink eyes and stuff. We certainly treat a lot of that ourselves, and or choose not to treat it, which is I think part of what we're here to talk about. And I think what we're really from my perspective, since Dale had presented to us as a group and we're working on our prescribing patterns, what we're really trying to avoid doing is treating a viral conjunctivitis so that a child can go back to school. Because when you treat the viral conjunctivitis, you're not treating anything. You're using a medication that has its own potential side effects. And we really haven't affected the contagiousness at all, and we're not helping that child. If it's bacterial, we may treat to shorten the duration, but we've learned, we don't have to treat it. It will still, go away on its own. So I think working on that understanding.
What about some of the daycares? There's still a few around. If my child has pink eye, they may say, okay, you're out until you get a doctor's note. Well, if I or my wife is working and we have to stay out of work for a week to 10 days, that's a big financial hit. And if you triage someone over the phone, you say it's simple, it'll go away, just wash up, be careful. But how do I get my child back into the daycare if they still want, like the old days, going back to school? You had to have an all-clear note from the doctor.
We are working on that. And one of the things this whole topic has brought up is educating the community, including the daycares. And we're working on that. I mean, Marnie's involved closely with some of the daycares and trying to educate everybody, because many of the people who work in the daycares are not medical. And fortunately, we have criteria also from the state of New Hampshire, Department of Health and Human Services, and using their criteria, that the daycare should be following the standards set by the state. So, the stuff is out there. It's just educating the daycares and the schools. And I have to say that there's been some misperception on the part of parents as well as the providers about what those policies are. And when we actually looked into it, for example, in the local school districts, it turned out that their policy was not exclusion. And it wasn't that the children had to be treated with antibiotics before they could return. That wasn't their policy, but that was the perception. So educating everybody is a huge part of this project.
As I was reading some of the literature, it said that sometimes it's a 10 or 15-day incubation period for pink eye. So if Johnny gets pink eye while he's at the daycare, he may not have got that pink eye from the daycare. He could have been at a restaurant where someone didn't clean up and he grabbed the handle.
Yes. In fact, those viruses can live for weeks on hard surfaces. And probably the daycares are better than anybody at cleaning those surfaces.
At cleaning.
So, they've got the bleach out probably every day. So they're working on that. But, that's why the common cold is common, because that virus lives for a long time. And so you touch a doorknob handle that somebody else touched who had the virus shedding, and then you touch it, and then you touch your face, and that's how these things spread.
So in a lot of ways, it's kind of like chicken pox. You can already be exposed to it, and you're on your way of getting it, but you don't know you have it. And can you be passing it on during that period?
The shedding for the virus, once
for the
viruses are 2 weeks or so. So yes, again, that's why these things are so contagious. In homes, amongst family members, the spread of a conjunctivitis, just like the spread of a cold from one family member to another, can be as much as 50%. So that's close contacts.
So I think, because I have worked very closely with some of the daycares in the area, and I think the point you made earlier about, like, is the daycare an unclean place and so my child's getting sick? It's not, and I do think the daycares do an excellent job of cleaning toys, cleaning surfaces, having children wash their hands, having staff wash their hands. I think not that I think it, the literature supports that certainly children in, so we're talking about the young kids under school age, certainly children in daycare compared to children who stay home get many more colds, get many more stomach flus, get pink eye more often. I mean, that's just true because you're gathering a group of like-aged children together who are touching everything, and but it doesn't mean that there's a problem. It's just sort of the part of being in daycare. And I always tell parents, as they're going through this, that it's true they'll have more colds and things now, but it does build up their immunity, and so that doesn't tend to last year after year after year. It's more in their first year in daycare, kids will have more of those common illnesses. And I think our goal is to has been, and certainly interject, but to try to differentiate better which kids actually might benefit from treatment, and to only be treating those children and not to be treating children who won't benefit at all. And then to look at that school piece, and I think it was eye-opening when we looked at school policies and found that no, not every child with a pink eye, by the current school policy, I think we've talked with the nurses about, are there changes that sort of coming down the road that may be appropriate, but even by the current policy, a lot of the people would call in and say, my child can't go back to school without eye drops, and it turns out that's really not true. I think the current for the school system, you said it's that if we deem that they do need treatment, right now it's 24 hours before they go back at the school level, not necessarily at the daycare level. I think I'm a member of the American Academy of Pediatrics, and so I'm on email lists with them, and also get some publications from them by being involved with daycares. And they have this book called Managing Infectious Diseases in Childcare in Schools, and it's sort of a guideline to who needs to be sent home, who needs to be excluded, what are the criteria to come back. And in between, I'm not sure if it was the first and the second edition or the fifth, whichever editions but between the last edition I got a few years ago and the one that I got more recently, that conjunctivitis was a big change. So it used to be an exclusion criteria according to the American Academy of Pediatrics. And with this new set of guidelines, they said kids really don't need to be sent home for that. Now, that certainly I respect local school policy, and as a pediatrician, I follow it. So I don't tell people, oh, I'm going to ignore, I think the way to evoke the changes is through the education and through, I don't think it's appropriate for me to say, well, we don't have to listen to that rule. I definitely very much respect school policy, and that there's a lot that goes into it that's not just, my take on things. But certainly, so I never recommend to a family that we go against the current school policy, but I think we are talking with schools about, does this really need, and we've changed at the daycare that it's not, by the AAP criteria, it's not, you don't have to get sent home. You may or may not get treated, and that may still be appropriate for that child, but you don't necessarily have to get sent home because, like you said, they've been contagious. They got it from someone else who was contagious 3 weeks ago, and they have it now and they've been contagious.
And the good thing about that is then the parents don't have to stay home from work for a week. So, it's really a trickle-down effect to the entire community, how these children are managed, and what's appropriate for the community is, the appropriate treatment and education.
Because if you do away with the myths, parents don't lose money, children don't lose education, and you don't have to see patients that you don't need to see, saving healthcare costs.
And the medicine itself if it's not appropriate to be using, it's costly, and it has potential side effects. Separate from the whole drug resistance issue is that people think eye drops are benign. Well, any medicine has potential risk, and one of the things that the ophthalmology department would oftentimes see is side effects to medication. So these eye drops that are, what's a little eye drop? It can't hurt anything. It can create quite a reaction, allergic response, big swollen, red, itchy, painful eye. And so you've just traded one benign condition for the side effect to the medication. So there's a lot of reasons not to use medicines unless you really need them.
You were just talking about eye drops. A lot of parents right now, maybe too many, will say, oh, a little pink eye. And they don't know if it's irritation, and they'll run to the local store and buy off-the-shelf medicines without. They can have some serious consequences.
There are some that I would definitely not recommend. If things say, get the red out or allergy eyes or something along those lines, that does have some chemical in it. And unless you know what you're treating, I would not use those. Now, there's another whole class of drops which are called artificial tears, moisture drops, lubricating drops, and those tend to be very, very safe. And in fact, in pink eye, whether viral or bacterial, artificial tears is a very good solution. And I think a lot of the antibiotic that was used and people got relief from was really the lubricating effect of the medicine, not the medicine part of the medicine. So the artificial tears, which is available over the counter, is perfectly fine.
Keeps the kids from just scratching their eyes, rubbing their eyes.
Yeah, and also warm, moist water, even tap water, Keen water or something.
Yeah, Keen water. It's expensive, but it's good. When you talk about warm, moist in their eyes, part of again is one child, one towel.
Right, exactly right. And, hand washing and all that kind of stuff, because the viral or bacterial are contagious if, again, mom or dad are helping to clean the eyes but then don't wash their own hands.
Go from child to child.
Or to themselves. Yeah. The way that these things are transmitted is because a lot of this stuff, our hands are like giant magnets for this stuff, and then people like to touch their faces. So that's one of the common ways this stuff can be transmitted.
And you were talking about the children. My granddaughter, oldest one went to Head Start. The youngest one is going to Head Start. She just turned 4. But as far as coughing here, washing her hands and not sharing plate and food and stuff, they're better than any of the adults. So some of the good daycares are really teaching kids healthy.
Absolutely.
And kids will often teach their parents. So they'll tell their parents, you have to cough into your sleeve, or you need to wash your hands, or, I need to brush my teeth twice a day. I think daycares are great for that. And in teaching those healthy habits. And I think just thinking back on some of my comments about school policies, I think any school policy or daycare policy, everybody has the same goal of that kids can stay and get their education or their daycare time if it's appropriate, that we do want to prevent for certain things the contagiousness and trying to prevent the spread. Like you said, they're definitely teaching those good habits for kids to stay healthy. And I really think it was so interesting when we learned that there had been this misperception that the policy was in the school district was if you have pink eye, you have to stay home, and you have to get treated, and you can't come back. And when we learned and we're trying to teach parents, it's true that if we think you have bacterial and we start you on drops, stay home for the 24 hours, and that's currently. But that the school nurses were not trying to send people. It was just they were saying no. If they have the cold and their eyes are a little pink, like that's just a virus, and we want them to be able to be in school and be able to benefit from their education. So I found the daycares that we've spoken with, and we've Head Start being one of those, and the local school system very receptive to this dialogue, and I've really appreciated that.
When you talk about if I have a cold and my eyes are pink, it doesn't necessarily mean I have pink eye, and parents could jump to conclusion and then make a bad decision for the child.
Well, I think the common term pink eye is that condition. It is the condition you're thinking about. The difference is that this idea that this is the most contagious disease on earth and people need to be isolated, that's what's different. Pink eye is just kind of the general conjunctivitis. There is a very contagious condition, epidemic keratoconjunctivitis, and that does spread like wildfire through nursing homes, and there was a case not too long ago up at Dartmouth College. But this is rare. That epidemic pink eye is a rare bird compared to this very common pink eye, which, like I said, is the common cold. So two separate things, but it's all called pink eye.
I can't pronounce the word that you just...
The epidemic.
What's the difference between the pink eye and the epidemic?
The epidemic is, generally like the common cold is, 10 to maybe 40, 50% of close contacts would get it. The epidemic one will run like wildfire, and everybody basically who looks at you is going to get it. But those tended to have some common, solutions of contact lenses, or there was some specific thing that created this, and it's a different virus. It's a different virus. So if you see that many people with it, it would sort of set off a red flag. And those people oftentimes don't have the other symptoms. They haven't had a cold and been around other people who've had typical cold symptoms. So it's a little different, but rare, very rare, the epidemic.
You were talking about contact solutions. We've been talking mostly about children. Now let's talk about some of the teenagers and some of the adults. You have some people who don't want to pay for contacts, wear them way too long.
Right.
They're supposed to be overnight, or they may wear them for 20 or 30 days, causing some eye irritation, irrational. So that could fall under the scope of pink eye.
Yes, and that can be a very, very serious problem, because those people can get ulcers of their eye from overwear syndrome, and the overwear then creates a little scratch on the surface of the eye, and bacteria can get into that scratch and cause a very serious eye infection. So overwear syndrome with contact lenses is a
getting more and more
big
common.
problem. Mm-hmm. I'd say so, because of the reasons, economic reasons. I mean, if the contact lenses are supposed to be thrown away in 2 weeks, but they feel comfortable, why not go 4 weeks? Well, they're still feeling pretty comfortable. Why not go 6 weeks? Why not go 8 weeks? It's a money issue for a lot of people. Also, inappropriate overwear, so people sleeping in their contact lenses is a big issue. So their eyes look pink, but the difference there is that those people are usually very uncomfortable. Pain is a big difference between that condition and the sort of common pink eye condition, which tends to be irritating but not painful.
But for the adults, it could have life-altering results compared to kids with just leaky eyes.
Right. I mean, the benign, whether it be bacterial or viral conjunctivitis, those are generally benign conditions, self-limited, and people get over them. But the other serious eye infection, yes, can be vision-threatening. Absolutely.
What about adults with pink eye in the workplace? How would you tell them to act? Same as children?
I'm going to defer that to Dale, since all of my patients are children and adolescents.
Well, it's interesting because
Unless they work in a daycare, then I have some expertise with that.
Our own nurse at the hospital, asking her what are the criteria for when people should not come to work, and this again, it's the common cold. I think common sense, but you basically are as contagious as you are with the common cold. So depending on what your work is, what does your work say about coming to work when you have the common cold? Most works do not exclude people. I know at our hospital they want people to wear a mask if you're coughing, sneezing, and you're going to be around patients. Now some of our masks also have the eye shield. So you could have a full eye protection and face protection if you are exhibiting both the runny eyes and sneezing and coughing, what makes sense depending on your work environment.
You had talked earlier about the herpes with the cold sore. And if a child is touching it and he or she can get it in the eye, what happens then?
If they actually get, there's a few ways that kids can get herpes in their eye. They can get it. Babies can develop herpes that they contracted from their mother during delivery, and that can include conjunctivitis or keratoconjunctivitis, and that's a very serious infection. They also can get it at a later point from somebody with a cold sore, or if they have a cold sore and they touch it. If it's, and we always make the distinction of if it's in the skin around the eye, but the eye doesn't seem involved. And again, correct me if I'm wrong, but my understanding is, that's still skin infection, and that we can treat, unless it's a very young baby, and that's a whole sort of category in itself, we can treat with oral medication. If it's actually in the eye, so again, I'm talking about an older child, because very young infants with any type of herpes infection kind of require a big workup and to be in the hospital. So that's
don't want to see that.
Kind of beyond the scope, and we don't like to see, kind of beyond the scope of this. But if they have it in their eye, we typically still treat with oral medication, but we'll have them see the ophthalmologist to see how involved it is and to see if eye drops are also needed or not. I mean, we certainly get concerned if we see what looks like herpes around the eye, blisters and sores, and then the eye is red or pink with discharge. Especially if it's their first episode, we definitely have them seen. Sometimes for kids who've had that and then have it again, we know, okay, we can treat with oral medication, but certainly initially, and if it doesn't get better. So those are the times that I would.
Yeah, the oral treatment has made all the difference in the world in the eye infection as well. Because the topical drops themselves were so strong, and they had a lot of irritating side effects. And it's now been shown that the pills, the same pills that you treat if you have the cold sore here, can get very good levels into the eye. And so that's really probably right now the way to treat it. There are some new antiviral topical medications. It remains to be seen how much more value that's going to add. But some of these people who get recurrent herpes, you get them here, you get it in the eye on a recurrent basis. Some of those people have to be on oral antiviral medicine indefinitely, every single day, to prevent recurrence in the eye, because those can lead to scarring and blindness. Some of those people down the road need corneal transplants.
Yeah, so we certainly have a low threshold to send any child with, certainly any child with a suspected herpes infection in the eye to be checked out. And in children who get it recurrently, we may not need them checked out each time that day, but we're certainly in close contact with their ophthalmologist and talking about what to treat with and for how long and when they would need to be seen. And they get regular eye exams. They're followed pretty closely to make sure that their eyes are healthy and that the infection's been treated.
Yeah.
So what we're going to do now, we're going to go to a PSA break. Then we'll have about 15 minutes left, and maybe we'll talk about some of the other child and eye problems that children could have, and how you guys work together to combat and help hopefully cure as many of these potential problems as possible.
Sounds good.
You were the last to be born in a family of 7 brothers. That's why you had to sleep on the 7th bunk bed and you developed vertigo. And that's why you couldn't become a pilot and you had to study engineering. You patented 367 inventions, but only 3 made it to market. The clap-clap candle, the lazy runners, and the frit and go. That's why you don't have an apartment on the 16th floor, and you have it on the 5th. But that's where you met Carmen. After 237 dates, you finally proposed. With her, you had 3 children. The 4th ended up being a dog. It's not the same, but he adores you. Numbers change your life. That's why you should take control of your credit score by keeping your credit card balances low. For more tips, visit numberschangeyourlife.org.
This can't be happening.
This can't be happening.
Of course it's not happening. Armored car.
Listen, having money isn't about luck. Make your own coffee, save $1,000 a year. Feed me.
Feed the pig.
Want some to.
We back? Yeah, we're back. Oh, we're back. That was a quick 2 minutes. And when children are born, basically, you give them a number of type tests. What are some of the tests that you give them?
Related to the eye, or just
To the eye, or just some
in
of the
general?
eyes, hearing, some of the just general?
So in terms of in the newborn period, we
Yeah.
do obviously a full physical exam. We actually do that several times while they're in the hospital, or if they were born at home and they come into the office. We do a universal newborn hearing screen. So that's been implemented over the last several. I'm not sure when. I can't remember exactly when we started doing them, but that it's a universal thing that it's recommended for every baby to see if they have evidence of hearing loss or deafness. We do what's commonly called the PKU screening, but it's actually a metabolic screening. It's a blood test done before they leave the hospital, or again can be done in the office if they were delivered at home, that tests for a host of metabolic disorders, so issues with how the body processes things that don't lead to symptoms right away, that are treatable, and that if left untreated cause severe illness. So it's a way to pick up illnesses that we won't know about for years if we go by clinical symptoms, and by then it's too late for a lot of them to treat effectively. We can know in the first 2 weeks of life, and we can start treatment immediately. So those are the, I'd say, and then just following how they're doing, their weight, and how they're feeding, and how they're breathing, and how they're doing. So those are, I think, the big tests we do.
What would be some of the, but what would be some of the concerns or warning signs that a parent should, with a new baby or a toddler, that should, or to go to either the pediatrician or go to yourself about, you may have some problems with visions that may notice?
It's the other thing I was thinking about in terms of the eye. The other part of our exam we do is what's called a red reflex, and so we shine a light in their eye and look for the retina to come back red. And if it doesn't, that's very concerning, and we would send them to an eye doctor certainly immediately. And the main thing we're screening for is retinoblastoma. I don't know if it really screens for. Screen for others. So retinoblastoma, it's rare. I've never diagnosed it, but it's a tumor that babies can be born with or can develop in the very early period. And so if we don't get that nice red, it's basically we're looking for the same thing that, when you take a picture with a camera and you get the red eye that you're trying to get out, we want it to be there when we're doing that. So we definitely have the ophthalmologist check that. If the baby's eyes are kind of roving and wandering and they don't seem to be focusing on anything, we'll refer that. If their eyes are crossing in a fixed way, so if it's actually very normal up to, I think, about 6 months for babies' eyes to cross and uncross, their focus is very poor. I've been told about 2200. So, they really can't focus that well. So it's very normal for their eyes to sort of drift. But if one eye is always turned in and it's stuck there, or always turned out, or whatever, that's not normal. It's not normal. Or if they get to be past 6 months and that's still happening, that, you know, their right eye is always drifting in, you know, that's not normal. So I think it's hard to assess vision per se, because their focus is so, you know,
They will,
rudimentary.
though. Even
They will.
a newborn will follow a smiling human face. It's probably the greatest stimulus for the newborn. And very tiny babies, hours old, if you get your face right up to them and you just slowly drift, they will follow. So it's a huge stimulus, is the human face, more than any other toy or anything else you want to buy the kid. Just and they'll do that right from hours old.
What are some of the ages of your younger patients?
Newborn. One of the beauties of being a general ophthalmologist is newborn to 105. The whole spectrum. But probably the crossed eyes is, I would say, the most common thing that we're asked to see. Parents notice that an eye drifts out or in, and like Marnie said, in the first few months of life, it's very, very common because the stimulus for the eyes to be straight is an alert, awake brain saying, stay straight, stay straight, stay straight. And little babies have more time when the brain doesn't care than when they're focusing. Whereas an adult, as soon as an eye starts drifting, you'll see this in adults who come out from a movie late at night. One eye is closed because really what's happening is they're tired and their eyes are drifting and they're getting double vision. And the brain doesn't like double vision. But the babies don't have that kind of stimulation to the brain. So the eye drifting in or out is the most common thing we're referred.
We had talked earlier off camera about diabetes. A lot of adults, one of the things they talk about, amputation and blindness with untreated diabetes. The unfortunate part, we have more and more children that are overweight and getting diabetes. I don't know the difference between 1 and 2, but are these children at risk too of losing their sight, or as they come up with new medicines to help protect them?
Well, I think the studies have all shown that the most important thing in preventing any of the side effects from diabetes, including vision problem, is good sugar control. And when you're talking about, children diagnosed with diabetes, you're talking about a lifelong battle to maintain good sugar control. For the most part, we don't see children with eye involvement probably for the first 15 years of diabetes. It would be very, very unlikely. So they're kind of protected early on from the eye findings. But the longer you're diabetic and the longer you have difficulty maintaining your blood sugar, the higher your chance that something could happen to the vision. And then the adult onset types, sometimes the ophthalmologist is the first one to make that diagnosis because they're running around with high-ish blood sugars for long, long periods of time and they don't realize the damage it's doing to in routine eye exam when we see signs of diabetes before they even know they have it.
44 ounces of Coke for 79 cents. Not an eye doctor's dream.
No.
And so when I went to the ophthalmologist, he took a picture of my retina or back there. So that's what you're doing now to see if there's any degradation?
We don't use the picture for diagnostic purposes. In our practice, we still like the old-fashioned, dilate the eyes and look in there with our ophthalmoscope. If there's something we then see, we have a camera that can give us more information, but that's not our diagnostic tool.
That's good. Another thing that athletes, especially in high school, especially football, now you're getting more and more about concussion syndromes. And we all know that concussions can have an effect on your eyesight. What are you working with the schools and some of the other ones to try to, again, do away with the myths? A concussion is no big deal. it's just a head ringer and you get up and do it again?
Well, I can let Marnie talk more about the concussion, but from the eye perspective, I think the implementation of eye protection in sports is huge. Again, it's a mind shift in terms of, well, traditionally, you get banged up, and if you lose an eye, well, that's the price you pay. That's not the way it is now. So eye protection is part and parcel of most good sports gear. And we have a lot of young athletes who fortunately are wearing eye protection. But we see a lot of injuries directly to the eye from people who don't. But as far as the concussions, I think Marnie...
You can go to the Y and see people play racquetball and no one has eye protection. And
then I see them because, that ball fits perfectly in the eye socket. And...
the eye's a little bit softer than that ball.
Coming at the mile per hour that ball's hitting at, it's not a pretty sight.
Back to the concussions.
Well, I think concussion management has definitely been evolving. And what we've learned, I think the most striking thing in the studies that they've done is that kids actually take longer to recover than adults, and that the sort of long-term consequences can be greater. So when we're treating children for concussions, it used to be a very cookie cutter. Okay, if you have this kind of concussion, you're out of sports for 2 days, and if you have this kind, you're out for a week. And we learned that kids really, they're all different, and their brains are all different, and so it's much more individualized. We do take kids out of their sport. We sometimes take them out of school or other activities for a period of time, basically to give the brain a chance to rest. And then for the athletes, anyway, it's we have a great relationship with the trainers at the schools, and they can do. There's a test called impact testing, and it's a standardized, computerized test of kind of your brain, your reaction time, your cognition. I don't want to misspeak about the test because I'm not an expert on it, but all the high school athletes in organized sports, anyway, do that before their season. In contact sports, I don't think it's for every sport. And so if they get it, so football players are the best, great example. So they get it beforehand, they get a concussion. We wait till their symptoms are cleared, certainly before they can go back. But their school along the way does impact testing and see when do they get back to their baseline, because sometimes, they may say, I don't, and they may not have a headache anymore or dizziness or blurry vision or whatever, but their impact scores are still low, and we know it's still not safe to let them return. So it's really we've just learned a lot about what the brain needs to heal, how much time it needs in terms of what signs tell us that athlete is ready to go back, as opposed to saying, oh, you were knocked down, but you weren't unconscious, you're just out for a week. It may need to be more, it may need to be less, and so it's really much more individualized. For the kids who are not high school athletes, who are younger than high school or don't do a school sport, or it's not a contact sport, they don't have that impact testing, but we go a lot with the symptom management. And all the other thing we've been doing is slowly increasing them back to activity, so they don't go from being told, a note says no gym, no sports, to full activity. So we have them start, do some jumping jacks, do some running. There's actually a formal process the trainers can do to make sure their symptoms don't come back on this graded exercise routine.
About a year and a half ago, Sports Illustrated had talked about the impact test. They took a group of football players, I think it was Iowa, and they went through their whole high school career, and some of the kids had some really serious damage. But what was one of the most surprising things was it was a lot of kids who had minor head injuries or impact. I said, oh, it's no big deal. You guys can't suffer a concussion. You can't cause, say, eye damage or whatever, because that was just a mild thing. But in some cases, it's not the force of the injury. It's just individuals. You can suffer quite differently.
And I'm not sure who was asked. Was the athlete, the one who was asked to assess their own level of damage or objective testing?
What they did was they did the test and they filmed the athletes the whole time, and then they had a couple of the mechanical scientists looking at stuff, and it was some of the real simplest. So if I can go see my grandson can fall, and I go, it's no big deal, but I have no idea the damage of that head injury just by looking at it.
Right.
So that's when it becomes important to you, especially 5, 6-year-old kids, because they don't get concussions, right?
They certainly do. It does get harder to limit their activity the younger that they are. Like if you have a 4-year-old with a concussion, to say he can't do exercise, for a little while his symptoms will limit him. He'll get a headache if he runs around, but then there's definitely this period when somebody can be pretty active and not be that symptomatic. And for a little kid, it's really hard to limit their activity sometimes, but we try.
We got a few minutes left. What we're going to do, I give you the opportunity to talk about some of the concerns that you have with an aging population, how Asian population, and some of the medical concerns about eye illnesses. They have myths, or they just tend to overlook until it's too late.
Well, I think there's been some great new treatments for some of the previously blinding illnesses for the elderly. Probably the most dramatic is in a condition called macular degeneration, which really 5 years ago there was no treatment, and unfortunately, we still have many patients who are legally blind because of macular degeneration. In the last 5 years, there are now some eye injections, which, if the condition is found soon enough, are amazing in preventing further damage and even improving vision. So that's probably, I think, the most remarkable change in treatment for the elderly. Cataract surgery has been around and very successful, for decades, compared to, let's say, when great-grandparents were put at bed rest with sandbags over their eyes for 2 weeks after a cataract surgery. The state of the art of cataract surgery is just incredible, and people within 45 minutes basically are in and out of the hospital with cataract removed and implant placed and restoration of vision. And I think it's one of the most common procedures performed in the United States. So I think for the elderly there's great hope for further improvement in vision.
What were concerns that you would have for parents when they should, again, some of the myths that they should overlook? And I know I'm putting you on this. Some parents will say, hey, my child, if his hearing isn't good or if his eyes are not good, wait until they're 4 or 5 years old. Let's not worry about it.
I think as far as that goes, I think there's definitely things with hearing, with vision, that are much better intervened early. So the whole impetus behind newborn universal hearing screening is that historically we didn't really know that certainly kids that are profoundly deaf, parents might pick that up. They don't startle at sounds, they don't turn to noises, they don't listen to their mom's voice. But kids with the mild to moderate hearing loss would not get picked up until they were 2 or 3 and they weren't speaking. And then they've missed out on all that language development time. And now we can intervene. I think with vision, similarly with those kids whose eyes are crossing past the 6 months, that's a key time for brain development. And if their brain is not getting the appropriate input, it'll just shut down. And so then, there's a point after which you can't regain vision in that eye, or not good vision, because your brain has just not made those pathways. So that's something I've sometimes had families are like, well, let's see if it straightens out. And I said, it's probably not going to. And and again, this is for the ones that are fixed in place, not the before 6 months, lazy eye drifting because they're tired or whatever. So to say we can intervene now and they can have normal vision in that eye, in both eyes, or needing to, whereas if you wait, that cannot always be fixed.
Well, I want to thank both of you for being here. I know we went more than the pink eye, but I think the public would benefit getting rid of as many of these myths as possible. Again, thank you for being here, and hopefully we'll see you on the long road.